Members, it's the appointed time. We have a quorum. The government officials have joined us for the meeting. I will call the meeting to order. Agenda item number 1. Engaging district services and community care teams to assist in welfare support. That's paper CB bracket 2 260 stroke 2024 bracket 01. Members, we now give the floor to the government to walk us through the paper. There are PowerPoint slides. The government, please walk us through this pilot scheme. Over to you. Thank you. Members, we're here to brief members on the pilot scheme on district services and community care teams to support elderly and carers. The 2023 policy address proposes mobilizing care teams to visit households to identify the carers of singleton elderly, doubleton elderly households and carers of elderly persons, and then refer these people to social welfare service units for follow-up. The care teams will also help seniors and PWDs to install and use emergency alarm systems. This is to minimize the risks of accidents. In May 2023, in Chunwan in the Southern District, care teams were support. A network is already in place. The care teams there have built up experience. So we will use those two districts as testing ground. Last June, I joined the Commissioner for Rehabilitation and also the district office of Chunwan. We did home visits. We learned about how to leverage the network and the experience of care teams to support the carers of seniors and PWDs. Last month, the SWD invited the care teams from a sub-district. We also trained them on communication skills and gave them information on welfare services. We got a good response. Then there were 19 care teams in Chunwan and 19 care teams in Chunwan and 17 care teams in Southern District. My team will also brief members on the latest progress of the schemes with the care teams. Please. Thank you, Chairman. As the Undersecretary said, there were two measures under the policy address. First, engaging care teams to identify singleton and doubleton elderly households and carers of PWDs. And second, getting care teams to help refer persons in need to install the emergency alarm system. It's a 12-month pilot scheme. The scheme will be up and running this month. There are 19 sub-districts in Chunwan and there are 17 in the Southern District, so in total 36 care teams. We serve 4 kinds of people: singleton, seniors, doubleton elderly households, their carers, and also the carers of PWDs. So first, the care teams identify the households in need and then provide follow-up services. This means home visits, calls, phone calls, and also getting those people in need to take part in activities. Now, follow-up services. Now, these households have needs, so the care teams will refer these households to welfare services, such as assistive devices. Say someone has returned from the hospital to home, they may need crutches and wheelchairs. So the care teams help these people in need to apply for those devices. Care teams also help the people in need fill out application forms for welfare services. Care teams can organize sharing sessions and other activities to show continuous care to people in need. Care teams also refer persons with disabilities and seniors to apply for the emergency alarm system and have those systems installed. When care teams spot people in need of financial assistance or other needs, care teams refer those cases to the social welfare department. The district offices of the social welfare department will triage cases and then refer them to the services such as mental recovery services, rental of devices, and also application for financial assistance. We have different elderly support centers and also support centers for persons with disabilities. For straightforward cases, those cases can be referred to such centers. We provide subsidies to care teams. There are key performance indicators. The district welfare offices look at the local conditions and talk to the local care teams in coming up with the KPIs. It depends on the service volume. The subsidies range from $160,000 to $240,000. Now the timeline: in mid-February, we invited care teams to take part in the pilot scheme. All the care teams in the sub-district have applied for this pilot scheme. Care teams members will receive training. They are in fact undergoing training now. They will pick up the basic communication skills and learn about the local welfare services and the referral workflow. We want to familiarize care teams with these information procedures. On March 28th, that is this week, the pilot scheme will start. Care teams have to submit service data to the SWD regularly. We also keep an eye on the progress and the success of the scheme. The district offices of the SWD will remain in touch with the care teams and provide assistance to make the scheme a success. That's all from me, Chairman. Anything else from the government? If not, I now open the floor for questions from members. 4 members are waiting to speak. 4 minutes for each member. Questions and answers inclusive. First, Dr. Tik Ji-yun. Thank you, Chairman. It's good to have more people care about the carers. But showing care towards carers shouldn't be the same thing as professional services. We are now engaging care teams to do a range of tasks. I have questions. Care teams are local residents. They are dedicated people who help others out. Care teams will get training, but I doubt care teams can do all that work because as a social worker myself, I know the tasks care teams are expected to do will require expertise. You're just giving $100,000 in subsidies to these care teams. So how can care teams be expected to deliver so much? If care teams can deliver so much, indeed, then the care teams are really jack of all trades and they're expert in everything. Just then we had a scheme about persons in mental recovery, and we expect care teams to do something about that. So my worry is that care teams are expected to do just everything. I know care teams have KPIs. What's the breakdown of the KPIs? So are we just hoping that care teams will work on something and consider those problems taken care of? We're just getting people to contact persons in need, but we need results. So we need details on how the tasks are divided up, how we can truly help the carers. Now my second question, it's a broader question. We want a full range of services for carers. In a unit, there may be leaky pipes, and then the government sees the problem and adopts a band-aid approach. I see piecemeal fixes, but not a holistic approach. For carers, they need financial assistance. Apart from the 10,000 people who will get support, are there other forms of support? Now, social support. carers have different needs. Who will provide the social services to carers? The paper mentions referrals to welfare services or centers for persons in mental recovery, but those centers have their plates full. I'm sure there are cases that need in the community, but when we do spot all those cases, can we cope with all those cases given the resources we have? Now we have around-the-clock support service for people with emotional struggles. Can care teams help them? Now, on-the-job support. I'm looking for a comprehensive system of support for carers. I don't want to see just band-aids. If the existing services are good enough, then we won't need to have this meeting. We won't need this subcommittee. So now we have care teams do all the work. How will the care teams split up the task? What's the workflow like? How do we measure the success of the care teams? Can we get the officials to tell us more? Over to the government. Thank you. Dr. Tick used a great analogy. You can think of it as a flat in poor conditions. We cannot move the people out of the flat and have a major renovation. The resident needs to stay there. That's why our support system cannot be built from scratch. We can only offer small fixes. We have to do a piecemeal approach. We cannot tear down everything and build up an entirely new system of support from scratch. We cannot move the existing residents out, to stick to that analogy. So our improvements to the existing system can only happen in a piecemeal fashion, and that's our long-standing practice. The existing support, including the elderly community centers and neighborhood elderly centers, those services will remain in place. Care teams are volunteers who visit the households in need. Care teams find out the needs of those households and then they refer those people to services. This is a pilot scheme. We first try to find out the cases in need. We try to match them with the existing services. If we find out a huge number of cases, then we would think about solutions. If we can cope with the cases uncovered, then we will let the existing resources do the work. So there's a clear division of work for our volunteers. The idea is clear. The care teams refer people to the services. So the care teams need to be able to spot the cases. We're not expecting care teams to do professional work. So there's a clear division of labor on what the care teams are expected to deliver. Any follow-up? Dr. Teck Ji-Yu. How do you measure the success with the key performance indicators? How will you measure the success with the KPIs? The district welfare officers and the care teams talk and they agree on the KPIs. So the district officers talk to the leaders of the care teams. The KPIs may vary from district to district depending on the district conditions. Are we talking about differences in numbers or are we talking about differences in directions in terms of the KPIs? The numbers will be different, so the levels will be different depending on the size of the district, but referral will be a direction shared by all districts.
Next, Ms. Lam So-Wai. Thank you. I basically agree with the idea of the pilot scheme, but as Dr. Tick said, there are many operational issues that we need to mull over. We need to think how we can implement the scheme, what is the effectiveness of the scheme, and as a social welfare worker, you mentioned community care teams have basic training like communication skills, service contents, and the referral mechanism. Some care team members may be smarter, but as some of them are retirees, how are you going to train these people? We need to identify singleton elderly, doubleton elderly, or even families in need. What assessment tools will we use? What about questionnaires? Any forms like a checklist? This is under the portfolio of welfare. We are discussing the issue of carers. But there are also many suicidal cases. These happen every day. It's tragic in Hong Kong. There are suicide cases. There are also other tragedies in Hong Kong. The crux of the matter is the mental health issue. So actually departments should work with one another. For example, the Health Bureau should also join the collaborative effort. We need to have a case management model in the community, like the incident that happened in Diamond Hill. That was also an issue related to carers. The community lacks a case referral mechanism or a high-risk case identification system. So let us take a step back. Have you identified the root of the problem? Case management model is important. There are different teams under the SWD. There are also services provided to different categories of people. There are people with disabilities. There are people in mental recovery. You said that you are going to provide training to care team members. There are team leaders, team deputy leaders. But can we make the training targeted? You also mentioned the emergency alarm system, EAS. How do you assess the effectiveness of the scheme? How often will a review be conducted? We need evidence. So how will we conduct reviews? Thank you. As I mentioned clearly, we don't expect care team members to be professionals dealing with the cases. So actually, I'm not versed in the assessment tools mentioned by Ms. Lam, but I've been working at the community level for a long time. So I can actually identify problems, people in need in the community. For example, elderly persons in need. My experience is that some people are not aware of the services available. Ms. Lam mentioned quite many services. Ms. Lam, you are a social welfare worker, but volunteers do not know them all. So we do not expect the care team members to be well up in all these areas. That's why we hope that social welfare workers will be able to step in and provide assistance. We don't expect care team members to provide direct assistance, but then we hope care team members to identify people in need, and then they can refer these people to the social welfare office so that there will be social welfare workers providing assistance. Care team members do not carry out the assessments per se. Just now, Ms. Connie Lam also mentioned collaboration with the Health Bureau. We'll get to that later on. There are different life problems leading to poor mental health. So how can we improve the living standard of these people? These are actually more urgent. It'd be all too late when we refer the cases in which in these cases already have mental issues or mental health issues. I'd like to follow up. I know some care team members. Well, I actually think that care team members should not be scared off by the cases. Some care team members may have been scared off by the cases, so I'd like to incorporate this element in training. For example, how to deal with the cases or the subjects when they are visiting the households of these people. Well, I think this should be incorporated in the training. Next, Ms. Lillian Koch. Thank you, Chairman. I'd like to talk about something practical first. Each team will be given allowance of 160,000 to 240,000. It may depend on the size of the subdistricts and so on. How long will it last? That is the duration of the pilot scheme. I mean, does it last 1 month, half a year? Next, if we are really going to expand the scheme to all 18 districts in Hong Kong, how much public fund will be needed? When we are going to implement it, we'd like to know whether the public fund is used well. When you are going to pay door-to-door visits, well, I think this is indeed good. This can enhance neighborhood support. We'd also like to spread positive vibes. All care team members are volunteers, so it's actually a good idea to spread positive energy or vibes in the community. There are also many singleton elderly, or there are so-called hidden elderly in the community. I talked to some government departments. They said that the housing department may be in a better position to have an idea of the situation. They may be able to pick up some cases more easily. Just earlier this year, a singleton elderly passed away at home. I could step in time so that we can deal with the case in a timely manner. Social welfare workers actually work on these cases, but how can we encourage or allow the community care team members to identify these cases faster and more easily? That is, there are still some hidden cases in the community. So how can community care teams actually spot these cases in the community in order to strengthen support? The other two members also mentioned the same issue. The community care teams are full of dedicated people. They should be given basic assessment tools, techniques, and so on. For example, they need to be able to identify mood swings, any emotional change. They should be able to identify such changes. I also visited some singleton elderly when I was studying in secondary school. We were briefed on the simple procedures, what to do on site. We also needed to report the situation of the elderly persons. We needed to report the specifics to the social welfare workers. These may be clearer guidelines for care team members. 3 questions first. For training, I'll invite the SWD to take it. We don't have any figure in relation to cost. This is a pilot scheme. Are we going to further expand it using this model? We don't know yet. You can calculate or arrive at a ballpark figure, but we are not sure about how the situation will pan out. There are services provided by the SWD to take care of elderly persons in the community. There are so-called hidden elderly persons in the community because they are not willing to step out of their home. There are schemes of the Jockey Club. They have door-to-door visits. There's word of mouth to help identify elderly persons in need. So it actually offers an extra protection, a layer of protection to identify more people in need. Next, Ms. Maggie Leung. Thank you, Ms. Lillian Kwok. We've designed some preliminary questionnaires. For example, through chatting, community care team members can collect more information. For example, do the elderly persons take part in other community activities? Are there any recent problems that they couldn't solve? Care team members can refer them to suitable service groups or services. I'd like to follow up on her reply. For the figure between 160,000 and 240,000, is it for one whole year? Yes, for 1 year per team. Will you work with the housing department? They are more relevant in the situation. They can identify singleton or doubleton elderly people more easily. They can expedite the situation. There's the support for carers project, and security guards already have the awareness. We can see how we can further enhance the project later on. Next, Ms. Doreen Kong. Thank you, Chairman. I've read the papers submitted by the administration for community care teams to take part in the pilot scheme. I'm a little bit worried. I've been concerned about carers. This is actually a fragmented approach, and I think there is duplication of resources. There are community care team members, and members can refer the cases to social welfare offices, and these offices can also refer the cases to other NGOs. Do we still need community care teams in the front line? We are going to give them hundreds of thousands of dollars. If we need to fare well in policies on carers, we need to have comprehensive action agenda. We need more than people. We need both people and policies in order to take forward these projects. People alone won't suffice. You also mentioned training. Now that we don't know the effectiveness of the pilot scheme, why do we still need subsidies ranging from $160,000 to $240,000? If there are indeed subsidies earmarked, they should be given to NGOs. There are many NGOs in the community. If they lack resources, we can give them subsidies. Do community care teams have the access to database? Probably an NGO already tries to get a hold of an elderly person for a couple of or for a dozen times, but still, the elderly person still can be contacted. I'm afraid there may be duplication of resources. If the people that are going to be helped by the community care teams are exactly the people being helped by the NGO, as a taxpayer, how can I make sure that there won't be any duplication of resources? I've taken a look at the situation in Singapore. On the duplication of resources, They have the best management, actually. Singapore is not very large, but they have set up 55 district resources centers. People entering the centers can ask for services. Then the 55 district resources centers will open until 9 p.m., and the information will be fed to the suitable NGOs. This will involve the slightest duplication of resources. We don't need an extra team like community care teams. They are already very busy. Thank you.
Undersecretary, we do have integrated centers too, but we're talking about hidden seniors, people who do not approach those resource centers. That's why we have this pilot scheme on care teams. Now, on the different teams and people involved, care teams are there to refer the cases in need that they have spotted. Now, on the district centers, the centers assess people's needs. Non-governmental organizations are the service providers. So the roles are clear for each party. If any party struggles to tell what their role is, we can let them know. In our service agreements, we set out the KPIs. Each party has a role to play. The centers look after the seniors in each district. We get care teams to help us spot the hidden seniors. That's the policy goal with this pilot scheme. So that's how the different parties interact. Now, other members have spoken for the first round. After my turn is over, and then we will see if we have time for the second round. But I think there will be very little time left. So my turn. A question for the government. I support the direction of this pilot scheme. Carers, singleton elderly household, doubleton elderly households, they are in urgent need of help. I don't see where we can find a large pool of people to cover this massive effort. We will need care teams to help out. The government will provide resources for care teams. From other members' comments, I get the impression that we want to see a targeted approach to the work. So, for the government, there are cases already on the radar of the SWD. Some cases are already approached by NGOs. These people may be seniors or carers. So in that case, can care teams skip these people already served by NGOs or the SWD by other means? And can we talk to the housing department and their security guards? For cases already covered by existing services, can we skip those cases to save resources and avoid resource duplication? The pilot scheme will cover 2 districts. Under the pilot scheme, will the care teams build up a database, and eventually we can tap the big data? The government does not maintain a database now, but with the pilot scheme, can we build up a database of the cases? Now, on training for care teams, I don't know if the training is over yet, but can we look at the training? If members of the subcommittee can take a look at the training, then I believe members will see some of their questions answered. So we would like to get a sense of the training. If the training is very thorough, then we are all good. Now, for the training, how many hours of training are we talking about? Have care teams flagged any issues during or after the training? After the pilot scheme is over, can the government work with other social stakeholders, such as secondary schools? I got involved myself. An NGO can organize visits with secondary students. secondary students can talk to local residents. It doesn't have to be home visits. We can simply get secondary students to give a call to grannies and other seniors so that we can encourage secondary students to serve the community and possibly joining care teams in the future. Chairman, on the frontline operations, Ms. Maggie Leung can tell us more in a moment. Now, on gathering data, when care teams do home visits, we collect basic data such as the addresses, phone numbers, financial condition, situation of the carer and the persons receiving care. We put together the data for us to get a better sense of the needs of the carers. And then we can provide more services to carers. After the scheme is up and running for a while, we will build up the data, but the usage will depend on future conditions. Now, Ms. Maggie Leung can tell us more about the frontline operations. The training. Today, there is training going on. It's about the workflow of the referral procedure. So when care teams come across a carer or a senior and realize the senior or carer needs service, the care teams will learn about how to refer them to services. The social welfare district offices have talked to care teams too, so those officers tell the care teams about the local welfare services. And the training now is also about how to talk to seniors. So care teams learn about how to do an initial assessment of the seniors and how to refer them to the services. After the services are up and running, there may be a need for ongoing training, and then we will take note of members' training. How many hours of training have been given? So for a care team to take part in the pilot scheme, how many hours of training are there? We don't have a hard and fast number on the hours of training. It depends on the issues that care teams encounter when they do home visits. We will remain in touch with the care teams, so we don't have a rigid number of training hours for care teams. 3 members and I, that is 4 members plus me, we will be speaking for the second round. We have up to 3:30. So let's do 3-minute rounds. Dr. Tik Ji-yun. Thank you, Chairman. Members agree that this pilot scheme is a good idea because we're mobilizing community resources to help carers. But can the pilot scheme truly work? The government's response is more of a skeleton in nature. We just get an outline. But then on the specific tasks and how the subsidies will be used, we simply get a rough idea, and that's it. We want to see results. So why don't we combine care teams with NGOs? Care teams are under the Home Affairs Department. So the Social Welfare Department will struggle to keep track of the work of care teams. If instead we have NGOs partner with care teams, let's do partnerships. NGOs have the experience. NGOs can serve as a consultant that gives advice to care teams. NGOs can also sit down with the care teams to sort out the issues care teams run into. As the government told us, continuous training matters. We need to look at the actual situation, actual cases care teams encounter. We cannot just do generic trainings. Now, the next point is about assessment. With partnerships of care teams and NGOs keep an eye on the situation, and then we can have the NGOs help assess the performance of the care teams. I believe many NGOs will be happy to team up with care teams. After all, but in that case, resources will also be needed for NGOs, but a modest subsidy will do. Here, we can have the combination of district networks and also resources. empowering NGOs in that way will give me greater confidence. Can you also allow time for the government to respond to your questions? Undersecretary. Chairman, the SWD can elaborate on the details in a moment. Care teams will refer the cases they found to the elderly community centers and neighborhood elderly centers. NGOs run the district elderly centers and neighborhood elderly centers. Those NGOs, as operators, have their way of operating the centers. My question is, the care team refers cases to different centers. My point is, when an NGO helps out in all the work and keeps an eye on the success of the referral, the NGO can provide professional input. Chairman, let's see if Ms. Maggie Leung can elaborate on the operational details. Under the pilot scheme, the Social Welfare Department keeps an eye on the cases. We don't want to overburden the care teams. So the pilot scheme works like this. The Social Welfare Department centralizes the referrals. Of course, care teams can also refer cases directly to elderly community centers and centers for PWDs. I'm sorry, I just don't see how that can work well given the current approach. Getting NGOs involved can bring in professional input. Dr. Tick's point is that the elderly community centers have their plate full. So we need to strike a balance. That's why the Social Welfare Department will also come in with a referral. Let's see how the pilot scheme works, and then we will find a way to improve the work. You can do some comparison and contrasting. Let the government decide which option will work better. Next, Ms. Connie Lam. The Social Welfare Department staff are under immense stress. They have their plates full. I know people who work at the Social Welfare Department. So that's why a member suggested that NGOs team up with care teams. And we can find case managers from NGOs. Let's do a case management model. Say someone from a care team works with an NGO. They go on a visit together and they find that someone in a family has all kinds of needs, mental health needs, learning needs, among other needs. And then we go to a certain case manager. And then the NGO can match that household with all the services it needs. This is professional work. The care team cannot do the work. So the case may be matched with the ICCMW and other kinds of departments. And also, let's also bear in mind the personal privacy data ordinance. Say a household accesses different centers for elderly services, family services. That household has to sign a statement on their personal privacy under the Personal Data Privacy Ordinance. This is an issue that needs to be sorted out for the SWD. We have all kinds of technology these days. There are electronic platforms. Will there be a platform or a pool of care teams accessible to different policy bureaus? So when a bureau goes on the platform, they can find out all the details and service needs of the different cases. And all bureaus can access the information. They get a sense of the needs of the families, and that's how we can deliver better district services.
Thank you. We do want to achieve a balance between taking good care of people in need and protecting their privacy. There are many factors at play. We have a system, and I can invite Ms. Maggie Lang to supplement in a moment. The overall information will be added to the system. We want to streamline the procedures. There are service units within the NGOs. First of all, they need to get done the KPI they have agreed with us on. So I understand that they have heavy workload. They have a lot on their plate, but this is meaningful. Ms. Maggie Lang? Well, let me first add a little bit. We do have partnership with the NGOs in the community. They team up with one another, they work with one another, they aren't supervisors of one another. For example, in a subdistrict, there are centers serving PWDs, there are also centers serving elderly persons. So they team up with one another and they work with one another. And the pilot scheme, even before the launch of this service, there's a lot of communication among them. We've listened to members and will consider members' comments. True, it's the social welfare workers who are the case managers of the cases. As the Undersecretary said, community care team members are volunteers who have gone through training. They can then refer cases to the SWD. Social welfare workers can then act as case managers to take care of the cases. So in case of elderly people, they will be referred to the relevant centers, whereas persons with disabilities will also be referred to centers serving PWDs. Regarding data, how will we balance between personal privacy and taking good care of these carers? This is something that we need to consider in the future. Thank you. Ms. Lillian Kwok, I'm a little bit worried. Chairman, just now you also asked about the hours of training, but then the Undersecretary said that there is no fixed number of training hours. It seems to have cover a lot of contents, however. Training is all about the learning curve and the effectiveness of the courses. You simply can't ensure, you simply can't assume social welfare workers or the course attendees actually know some contents beforehand. Can you give us more information about the course contents, hours of training, and so on? We'd like to have these pieces of information as reference. I'm no expert in this area, but I've been working in the curriculum field for 2 decades or so. I can also chip in with my own experience. The Undersecretary said that we can focus on the areas that we identify to be problematic. The administration said that they would see how they could enhance the scheme, but actually there is much duplication of resources. As I said, there were cases in which 5 social welfare workers are working on one single case. On policy schemes, can we identify the support being given to these units so that we can understand or we can find out whether there is any duplication of resources. Legislators can also act as monitoring agents to make sure that the services are more targeted. On operational experience, I will ask the SWD colleague to take these questions. On policies in relation to carers, in the papers of the subcommittee, every time we submit different papers to explain how we can assist carers from different perspectives. We'll have to consolidate these different papers. But as a general policy, we've already explained the situation at large to members through these papers. First of all, maybe on training contents. If you can't give us more information right now, probably you can supplement written information after the meeting. Ms. Maggie Lang, I'm not going to repeat myself. We've also invited clinical psychologists to brief the course attendees on communication skills. Community care teams will also refer cases to install the emergency alarm system. For example, for application, operation, these are also some of the course contents. This is a pilot scheme. Community care teams need to visit households first. Then we can identify what problems or challenges they run into. We'll keep reviewing the situation and we'll also see how we can provide assistance. Dr. Tech just now mentioned probably course attendees would like to know more about mental health support. Then we can strengthen support in this regard. I'd like to have different papers, for example, all the policies provided to carers, for example, existing policies, future policies. I'd like to have a consolidated table listing all these policies. Next, about the courses, I'd like to have a clear curriculum. I'd like to know the core curriculum, which are mandatory elements. What about some extra contents? So I'd like to have 2 supplementary papers. I believe the administration can easily give you information about training courses, such as guidelines, curriculum, PowerPoint presentations. The administration can give members this information. I wanted to come to this point later on. This is the second last meeting. So in the very last meeting, I'd like to have a summary. For example, what have we discussed? What have been conducted? We can summarize all these in the very last meeting, after which we'll report our work to the Legislative Council. We can save this to the very last meeting. The administration can also give us such information. Under Secretary, can you do so? In the last meeting, we can summarize all the services provided and our discussion. I can submit the paper to the Secretariat in a moment. Next, Ms. Doreen Kong. Thank you, Chairman. Just now, we talked about hidden elderly people. Let's not say whether they're hidden or not. This is not a positive situation. Some data and research show that while identifying singleton elderly people or hidden elderly people from 2000, there have been different surveys. For example, in 2008, there was a CUHK study on hidden hidden elderly people. In 2011, just then, Mr. Matthew Zhang also said that we are very good at Identifying hidden elderly people. There are some 41 district elderly community centers and 171 neighborhood elderly centers. Well, now I understand why we couldn't do anything at all. We're still talking about providing support, financial support such as $100,000, but we can actually achieve nothing. I'm let down. Back in 2000, the aging population wasn't as serious as it stands right now. We have an aging population right now, but we are still using the power of the community care teams. Elderly people are actually disappointed. There have been different research, different surveys. In 2008, for the CUHK survey, they said that there might be negative effect if the survey is not going to pan out well, as hidden elderly people do not like social contact. So agents contacting the elderly people should have full integration. There should be teamwork. For example, there should also be more coordination. All these are not mentioned in this 3-page paper. So as a member of the subcommittee, I'm indeed disappointed. On personal privacy, there are privacy issues in relation to family members, phone numbers, and so on. Is there any legislation or paper in addition to the PDPO that can protect the personal privacy of different elderly people? Cybersecurity is important, Undersecretary. As I mentioned, we need to strike a balance between protecting personal privacy and taking good care of people. We do collect basic information or personal particulars, or else it's impossible for us to provide suitable services. Regarding the first question, that is about identification of hidden elderly people, it's not the crux of the matter. We do need to identify hidden elderly people. The neighborhood elderly centers are working on this. There are some 10 staff members in these NECs. They take care of 2 subdistricts totaling 34,000 in total. So we need to rely on the power of local residents in order to identify elderly persons in need. They don't approach you. We need to knock on their doors to identify them. However dedicated or passionate the agents are, still, these elderly people may not let down their guard. Neighbors may be in a better position to help these elderly people. We'll take stock of the situation in order to make enhancements. Second round, I'm the last to speak. I've heard from all members. First of all, I still think that we need to take the first step with the pilot scheme. I had been a district councillor for 8 years. I kept visiting different households back then. I wasn't a professional social welfare worker. I'm still studying and training to be a social welfare worker. We do need to help singleton and doubleton elderly people. There hasn't been any such a large-scale project to help these people. The pilot scheme is a good one. In your review of the pilot scheme, you should collect feedback from the community care team members to see how you can make enhancements. We need to improve the living standard and livelihood of people in the community. Back then, there wasn't any subsidy, but then we have $160,000 to $240,000 as subsidies. There are some 20,000 people in a subdistrict divided by 6,000 people. Each community care team needs to visit 17 to 20 households. Probably 1/3 or 1/4 requires referral services. So I have two questions. Can community care teams really cope with this? Probably there's no KPI in relation to visiting all 6,000 households. But do you think the manpower of the SWD can cope with the situation? So these are my two questions. Do you have sufficient manpower to cope with the demand? Thank you.
Undersecretary, I was also involved in district work for 8 years. 8 buildings, 13,000 residents. I could not come into contact with every single resident because some refused to answer the door. I could reach at least 1 or 2 people on each floor so I could get a sense of what things were like with the residents. I talked to local residents as a district councillor. I got feedback from the local residents, and then I could refer those people to services. The same principle we apply in the pilot scheme. The Social Welfare Department can tell us more about the KPIs in a moment. We're not expecting contact with every single local resident, but we're hoping that the visit can give us more clues and make it more likely that we can reach the people in need. And this is from our experience. The SWD can tell us more about the KPIs. Now, we don't expect a home visit to every single household. But with more experience, the care teams will be able to pick up skills and they will get better at spotting the households with needs. In setting our KPIs, we look at the conditions of each district, and that's how we set a number of households that care teams are expected to reach out to. Again, this is a pilot scheme. We have to see whether the care teams can hit their target and whether there's a need to adjust the target over time. Now the question is, can the SWD cope with its staff? I thank everyone for their concern for the staffing at the SWD. We are building a safety web. We want to spot people in need. There are many subvented organizations. There are services for seniors and persons with disabilities. Let me return to the elderly centers as examples. The district elderly community centers can cover hidden seniors. Ms. Doreen Kong just mentioned there were studies on the elderly. The SWD has given extra resources. The elderly community centers have to cover hidden centers. The SWD works with the housing department and local stakeholders. We have been doing home visits. Now, the care teams will become part of the web. With these home visits from care teams, we're more likely to spot more cases, and those cases can be referred to NGOs. NGOs cannot get in touch with everyone, so the care teams can help. The care teams can help reach out to people. The work needs to be done by someone. You cannot have extra manpower. So can you cope with the services with your current staffing? Or you can take Dr. Take's suggestion, have partnerships with NGOs. Members, I've been listening to members' comments. Members support the pilot scheme, but members have also made concrete, practical suggestions. This pilot scheme will run for a year. My hope is that 6 months into the scheme, can you report to the panel on welfare services, and we can put our heads together about how to go ahead with the scheme. We have spent a good deal of amount of time on the item, so let's move on to the next item. Strengthening of peer support services and additional parents relatives resource centers. LC paper number CB bracket 2260/2024 bracket 02. Undersecretary, would you walk us through the paper? Over to you, Undersecretary. Thank you. The government supports persons in mental recovery, persons with mental health needs, and their family members and their carers. We help them maintain mental wellness, facilitate social integration, and we want to ease carer stress. This paper is about strengthening peer support services and setting up extra parents, relatives, resource centers to support persons in recovery. We want to help persons in mental recovery build up confidence and enhance their communication skills. With the parent relative support center services, we train up peer support, peer mentors, that is peer supporters. NGOs can deploy peer supporters to the different centers, halfway houses, and also occupational rehabilitation centers to provide rehabilitation services. The peer supporter scheme has worked well, so we plan to expand the scheme to cover the carers of persons in mental support and carers of persons with mental health needs. The 2023 policy address proposes strengthening the support for carers of persons in mental recovery. Starting from Q4 of 2024, we will have at least 70 peer supporters, up from 40. There will be senior peer supporters and also peer supporter positions designated for carers. Caring for a family member with mental health needs is a tough process. It's important to have survivors listen to their voice. Peer supporters can meet the family members and carers of persons in mental recovery face-to-face or give them a phone call. Survivors can provide an unbiased view and listen to what the current carers have to say. The carers will learn that they are not alone in caring for their family members. There are integrated community centers, halfway houses that provide services. Peer supporters can also be deployed to parent relative resource centers to provide emotional support and also go on visits and take part in mutual help groups. For family members and carers of persons in mental recovery, there is a center in Kowloon East providing parent-relative support services. There are counseling groups, activities, and also community education. The service helps them get better at looking after persons in mental recovery. There are also efforts to raise public awareness. Because of the special needs of family members and carers, the Kowloon East Center provides training and mutual help groups for families and carers of persons in mental recovery with different kinds of mental illness, depression, bipolar disorder, etc. These training and mutual help groups also focus on knowledge about response to drugs, communication skills. Carers also learn about how to get along with persons in mental recovery. There are different activities organized by the centers. The 2023 policy address proposes 4 additional parent-relative centers for carers of persons in mental recovery by the third quarter of 2023. So by then, there will be such a resource center in Hong Kong Island, Kowloon West, New Territories East, and New Territories West. We welcome comments from members. 3 members have pressed the request to speak button, 4 minutes for each member. Ms. Connie Lam. Thank you, Chairman. Now, on training persons in mental recovery as peer supporters, I support this idea. More than a dozen years ago, I was studying at the Poly U. At New Life Association, we were in similar work. We used art. We helped persons in mental recovery with making handicrafts, and they go on to help persons in mental recovery in the community. So this is going from mutual help to self-help for persons in mental recovery. This is a good idea. So we are getting survivors to help people feel someone is there for them. They will feel understood. They are recognized. And this is also something that means recognition for carers as carers. So how do we go about the training? What will the training cover? How many training sessions? How many hours? Who are the trainers? Are they social workers, psychiatric nurses, occupational therapists, psychiatrists, clinical psychologists? Who will do the training? Now, the peer supporters. There will be face-to-face conversations and phone calls to provide emotional support. How can you tell someone in mental recovery is competent and capable in providing emotional support? You need someone who has fully recovered to give support. For someone still on drugs, are they suitable for providing emotional support? Let's think that through. How do we ensure privacy when people use social message or messaging apps? We do outreach services. We provide emotional support on WhatsApp. For the peer supporters, do they also use WhatsApp or other online platforms, messaging apps? How do we ensure cyber security and privacy? Some people may not feel very comfortable to share their feelings. Are there alternative ways? Now, on the parent-relative resource centers, we will see such resource centers in different districts. Some patients groups and parents groups have told us that these people have lived in Chung Kwan O for more than 20 years. They are not aware of a certain support organization or certain resource center just in the same district. So when these centers are built in different districts, can these centers deliver what they need? Giving support to parents looking after someone with emotional needs is tough work. Someone may be a complex case with different needs. It's tough for the social worker. But at the resource center, it's a small space. You have limited resources. How can you deliver good services? The commissioner can tell us more. I will first address the question, and then the social welfare department can tell us more. Peer supporters are survivors of mental conditions. So first, we enlist people who are willing to give the support. The training will focus on communication skills. Peer supporters also help organize activities. So there is training on organizing events. The parents, relatives, resource centers are small. Few people know about these centers. The paper sets out the address of the centers. We also have a one-stop portal setting out the details about the centers, hopefully to raise awareness of these centers. When people organize activities, information about the centers can be shared and more people will learn about the services available. Some locations may be less than accessible and less than well known. The resource centers are a base. The resource centers team up with other service units in organizing training. So the resource centers don't do all the work. There is a center currently in Kowloon East. The Kowloon East Center cannot cover the entire city. But that resource center gets in touch with the other resources available, such as the local mental recovery resource centers. So the resource centers teams up with the other units. So you can think of the resource centers as a base. The resource centers can organize activities, but the events take place at a more convenient spot in the district. Maybe the SWT can tell us more about the details.
Assistant Director, Ms. Maggie Lang. Thank you. We hope that peer supporters can carve out a career path. So we hope that there will be suitable training. First, training on peer support and open employment. We require a minimum of 50 hours on peer support. What will it cover? The role and responsibilities of peer supporters, the concept of rehabilitation, recovery, interpersonal communication, risk management, contingency management, and more importantly, how to tell a story. Because peer supporters need to share with a lot of different people. They need to learn how they can share their own experiences. There should also be at least 40 hours on open employment, including career planning, interview skills, practicum experience. If possible, we will also arrange them to undertake some trial work. So they can look for their job in the future. So there's at least 90 hours of training. Next, Dr. Tick. Thank you, Chairman. This scheme is worth our support. Peer support is very effective. For example, in drug programs, in drug quitting programs, this is very effective. NGO manages the entire program, all services. As I mentioned, as the administration explained, that wasn't very clear. Unlike the previous topic, NGO support will be very effective. Just now we said that we wanted a list for carers. Right now there is no carer-centric policies. There are different centers catering for the needs of PWD, elderly persons, but then we lack a center for carers. Care teams do not just work on carers-centric policies. This is just one of their many responsibilities. Elderly centers are the same. They provide services not only to carers, so I think it's necessary to have a list. I want to review the services provided to carers attached to other centers. We need to see how we can enhance these services. Are these practices good? Will it help other services in turn? We should focus on carer-centric policies or services instead of having them attached to other centers. The aim of our subcommittee is to promote carer-centric policies. We want to highlight the assistance given to carers. With limited resources of the administration, it's important to reallocate all the resources. The administration said that they are just patching up the system. Probably we can also give them our views in the subcommittee. If we have a checklist, we can review the services in place. We can also turn services into carer-centric services, or what services are having a shortfall, we can provide more services. It's not a difficult task. You only need to provide us with a list, and the list will give us a full picture. It will stand us in good stead. Undersecretary, yes, we are talking about some dedicated centers. We can liaise with the Secretariat to see how we can prepare a table for a member's reference. We are discussing PRCs today. It may be a matter of the name, but it also focuses on carers. For example, how they take care of PWDs, children with special needs. These PRCs are also carer-centric centers. Dr. Tick is correct. For other service units, there are two sides to the same coin. Carers actually also have their burden eased as well at the same time. Meanwhile, we have also collected feedback and reviewed our operation. If possible, if the situation permits, we will set aside a corner or a little space. Carers can also take a rest. When parents take their children to services, parents also have a space to take a rest. Parents or carers can use a couple of hours to take a breather. Parents don't need to go to other PRCs to take a breather. When they take children or elderly persons to services, they can also take advantage of the time to take a rest. They can also talk to one another. This will be good use of resources, so we take a multi-pronged approach. PRCs are carer-centric, but in different service units, we also encourage parents or other carers to have time to take a good rest or to exchange views they can share with one another. I'd like to add something. Thank you, Chairman. We only focused on those being cared for. Right now, we are also caring about carers. This is good. We even need to double up our efforts in this regard. Anything else to add? Next, Ms. Lillian Kwok. Thank you, Chairman. Just now, Dr. Tick made some good points. Probably carers also need exactly the same thing as those being cared for need. We can make better use of resources. They can be more targeted. The government is closely monitoring finance. There are a total of 19 PRCs. What is the funding given to PRCs? How many cases have been dealt with by these 19 PRCs? What is the number of people being helped? You may not have all the information off the top of your head, but I hope that there will be supplementary information before the next meeting so we can take a look at the situation. I mentioned the needs of carers and those being cared for. In relation to peer support services, I'm a little bit worried. I'm in touch with quite a lot of persons in mental recovery. If a person being helped turns to a person who helps others, this is actually a very good and perfect story to tell. There is also some difficulty though. Can carers also have more peers? I work in an organization. There are some 400 SEN families. All of them are volunteers. They hug each other, they cry together in a park. These are actually good experiences for them to support one another. 2 children take part in Paralympics, and they also won medals. To give you another example, there are some divorced families, single-parent families. I follow up on these cases. The mother of these single-parent families forms their own group. They can team up with the centers in order to provide better services. We can render assistance to children in need if the parents are too busy to take care of their own children. There's the concept of community living room. Can we also implement a similar concept so that the grassroots or the beneficiaries of the community living rooms can also benefit from the similar concept? I do want to see proper use of public resources. We can forge cohesion in society, and we can also make improvements in different aspects of the work in society. Regarding community living room, I'll take this question first. Community living rooms are basically for subdivided unit households. Of course, if there are persons in mental recovery nearby, we do welcome them. But we don't want to turn the community living room into a place caring for persons in mental recovery. Probably those in the community living room have similar needs in life, so the focuses are actually different. Thank you.
資源嗰方面，
Ms. Maggie Leung from the SWD. In 2023 to 24, in the revised estimate for parents, relatives, resource centers, the expenditure was roughly $94 million. There were group activities with attendance of over 130,000 people. Now, on service users, more than 10,000 members. To get back to Ms. Kwok's great point about peer support for carers, this support matters. That's why we will commit more resources to create more peer support positions from 40 to 70. This will cover carers. Carers have a lot to share with others. This way, the novice carers will learn that they are not alone. Learning from survivors will help these new carers learn that they can get support. So there will be more peer supporters. There will also be more peer support positions designated for carers. Chairman, a follow-up question. I do see the large tallies, but I have some questions about the 19 centers. What's the funding? How many workers are there? Can we get a breakdown of the 19 centers? Can we get the details after the meeting? Just then I raised a point about the community living rooms for a reason. The SWD tells us that each party has clear roles and responsibilities, but when you have two units serving the same group of people, can we make the best use of the two service units? Are there areas where there are multi-function facilities, there is crossover? Is there room for making better use of the resources to serve the client? Let's put resources to good use instead of having all those fragmented and piecemeal services. Under Secretary. Of course, we welcome multi-use resources, but we cannot bring everyone together at the community living room. The CLRs are meant to be an extension of the living space for residents of subdivided units. I don't quite get the point of Ms. Kwok about how it works, but I will find out more from Ms. Kwok about how that works. One comment, Chairman. We're trying to build a platform. Doesn't matter how many people take part on the platform. We just need a platform. We need to let the people know that people can go to the CLRs. It doesn't have to be the parents, relatives, resource centers. The centers open up to maybe 6 p.m. So after those hours, people can go to the community living room and get together. So I'm just suggesting making good use of the CLRs. That's a suggestion for the government to look into. That's a suggestion. Any response from the government? Assistant Director. To get back to Ms. Kwok on the details on the workers, each resource center has 2 assistant social welfare officers, 1 social assistant, 1 welfare worker, 1 special childcare worker, 1 worker 2. Now, under the lump sum grant system, each center can make flexible use of the funding to hire workers. So we don't have the funding for each specific center. Chairman, can we get the government to give us a breakdown of the funding for each of the 19 centers? Next, Ms. Doreen. Sorry, Commissioner, do you have anything to say? On Ms. Kwok's point, under the lump sum grant system, each center, as long as it meets the service criteria, can deploy resources and manpower. So those centers do not have to submit the detailed information to the SWD. We may not be able to get hold of the information even after the meeting. Ms. Kwok, please wait for your second round. You have spent 9 to 10 minutes. Next, Mr. Rincon. In principle, I support the peer support services. The mental well-being of carers matters, and this is a major issue. There's an acute shortage of resources for the mental well-being of carers. Having the peer support service is better than nothing. We have many building blocks, but how do we put the building blocks together? And we don't know how all those parts fit together. I checked out the website of the resource centers. I don't see any information for general carers. I did find information on carers who are parents of children with special needs. So for the 19 resource centers, how many such centers have the resources for general carers? We're not just talking about carers of children with special educational needs, but each center has a website that seems to focus on children with SENs. If there are resources for general carers, then can I get those centers to update their website? There will be 30 extra peer supporters. For each such peer supporter, how many cases will each peer supporter work on each year? Now, my third question, how big is the demand? That is, the service demand. For sure, we have the numbers, and that's why the government proposes the extra 30 peer supporters. Do we have any survey? Do we have the numbers on the service demand? Undersecretary. There are different kinds of carers. Carers for ordinary children. Those carers sometimes need help too. We need resources also for carers of children with special needs. That's why we give help. That's why there are services and resources dedicated to such parents. That's why we have those parents, relatives, resource centers. We don't have resource centers for parents of ordinary children. We're talking about carers. It's usually the parents who serve as carers. The seniors in the household may also serve as carers. Maybe it's the relatives or parents. It's usually the parents looking after the children. Carers are people with special needs tend to need someone who can share their experience, someone who can listen. That's why we have, for general carers, carers of ordinary children, there are other channels, other options. Assistant Director. Among the 19 centers, one center is specifically for persons in mental recovery. The other 18 centers are for persons with disabilities. For carers of persons with disabilities in need, they can turn to those 18 service centers. Now, on the peer supporters, here is some data. For a full-time peer supporter, we expect the worker with the supervision of a professional social worker to go on home visits each year. The peer supporter will go on no less than 40 home visits. The peer supporter also has to help organize and promote group activities and public education, at least 72 sessions per year. The peer supporter is also expected to help organize events and share their experience. So that's for members' reference. Next, Ms. Connie Lam. On these resource centers, we have 19 centers. To ride on Mr. Rincong's point, I'm returned from the geographical constituency. In the building in Area 67 of Chengguan-O, there will be a Parents Relatives Resource Center. I have a suggestion. This subcommittee is about carer-centric policies. Why don't we have a one-stop center for carers? In Chengguan-O and Shaikong, there will be expansion works. Why not have a one-stop center involving the medical and social welfare sector? Why not have a carer-centric support center there as a pilot scheme? I was at the district health center in Shatin. All you need is a corner, maybe a couple of cups of coffee, just a coffee corner or tea corner for a carer to take a short break. 5 to 10 minutes would do. Let the carer finish the cup of tea or coffee, and then let the peer supporter listen to the carer, have a light snack with the carer. That's for the carer to relax. This year, we have seen many news reports of carers taking their own lives, and that's heart-wrenching. So this is for the government to consider. Let's make good use of this space. There will be an expanded Parents Relatives Resource Center. As the Undersecretary will know, can we do more with the center in Area 67? Can we set aside a corner in district health centers? Youth service centers have told me the ICYC's integrated community youth centers. Those centers are not visited by people. Those centers have space. Let's set aside a corner in those integrated community youth centers. Let parents or carers go there, and we get a trained volunteer, sit there, sit down with the carer, give the carers a respite, let the carers relax. Undersecretary, the Commissioner can tell us more about that. We thank Ms. Connie Lam for her questions. We have the Parents Relatives Resource Centers for carers. There will be a center in each district and one center specifically for persons in mental recovery. That may not be enough, and that's why for different service units, these service units may not even have to set aside a corner. They may have a spare training room for parents and carers to use. And they can have carers share their experience. I personally visited some such service units. A parent may bring a child to such a center. Other parents who are also there do cooking together, they do sharing together, and that's a delightful experience for the carers. It may not be the best idea to have a single place and bring together all carers to the single location. In each district, there are parents' relatives resource centers. The different service units in different districts can set aside a corner for parents who are also carers to sit down together and have a cup of tea. At the center I visited, the parents do cooking together, they do sewing together. The carers have fun there. So we will continue to take this dual-pronged approach to promote this approach. We thank the member for her suggestion. We will continue to stick to this two-pronged approach. Thank you.
Thank you, Chairman. Next, Ms. Lillian Kwok. Thank you, Chairman. It's good that at least there is support. Back in November, there were newspaper reports said that 60% of the carers had not heard about the resource center. I can't accept the fact that there's a lump sum grant, but I can't accept that we don't know how many workers have been engaged. So how can we review the effectiveness? How can we monitor the use of the resources? Just now, Ms. Connie Lam mentioned a coffee corner. They can take a break. There can also be classes of, for example, handicrafts and so on. But do PRCs ever work on family education? Family education is very important. How can we help them build a positive, harmonious family? How can we help parents build a positive family? You don't help them by just giving them some activities. That's not the way to help them. Whether there are any carers in their family, they do want to build a positive family. So you need to think what to include in the training. There should be monitoring arrangements. How are you going to monitor these aspects? Undersecretary, for details, I'll invite the Commissioner or the Assistant Director to take these questions. Do we need family education? We are talking about parents of persons in mental recovery or persons with mental health needs. We can consider adding family education later on, but we should grapple with the problems right in front of us first. First of all, the SWD does monitor the lump sum grant. While providing the lump sum grant, there's a typical establishment. But after giving the money to the NGO, the service indicator effectiveness, these aspects are covered by the SWD. They need to be reported. The establishment may be more flexibly deployed in the future. Some service units may be larger. There can be economies of scale. There can be internal deployment of resources, so they don't necessarily have to follow the typical establishment. That's exactly why we want to retain flexibility in lump sum grants. We want to enable organizations to deploy resources and manpower flexibly in order to meet the KPI. They need to report to the SWD, and I can invite the SWD Assistant Director to give you more information. In the lump sum grant mechanism, as we mentioned, organizations have the flexibility to provide services using the grant. We have service monitoring mechanism and guidelines to monitor the service, including service capacity and service effectiveness. For example, opening hours, users, services provided, frequency of activities. There are guidelines for all of these areas. Under these monitoring arrangements, the SWD visits users as well as organizations. We ask users whether they have the services they have expected, whether they are satisfied. We collect these pieces of information. This will help us gauge whether the organizations are doing a good job. Well, if that's the case, do they have information for all these 19 organizations? I do understand there is difficulty with organizing the information about lump sum grant. I am also one of the director of the NGOs. You said that you had collected some information, so you could have provided us with this information. You can consolidate the information about these 19 organizations, and you can give us information. When organizations ask for funding from the lump sum grant, we can only give the information about the lump sum grant instead of the grant given to each and every center. Well, I'd like to know the activities, users, and so on. After all, these are the 19 centers. They are from the 19 centers. So maybe after the meeting, I didn't speak in the first and the second round either. I'd like to say something in relation to the second item. The name of the center is not a carer-centric center, so how can you step up publicity so that carers will also know that the center can also give them support? You may need to do better in this regard. How many users can these PRCs help? In society, SWD has data showing that there are hundreds of thousands of people that need to be cared about. So we'll have 100,000 or so carers at least. Is it still not enough? It's of course better than none. So we support you to take the first step. But how can you support even more carers in the future? You need to think about it. The social welfare sector and different organizations also have their own carer centers or carer support centers. Have you considered how you can help them expand their service? Just now, Ms. Connie Lam mentioned Area 67. But there is already an elderly support center in Carer nearby. There is good software and hardware, but without your support, what they can do is limited. So on top of these PRCs, there are also some resource centers operated by NGOs. You can consider expanding these centers in order to cater to the needs of more people in the community. NGOs can apply for government's resources. For example, the one with Carer actually has applied for resources from the Jockey Club. Interested organizations can submit their proposals or application forms to the SWD, and the SWD will go over their application. But the prerequisite is that they need to, first of all, seek application from the private sector. It's good you have this scheme, but you also need to take stock of the response of application for these schemes. You mentioned that they need to seek support from the private sector first, so probably the threshold is too high. There may be resistance. Honestly, we have already given you what we want to achieve in relation to carer-centric policies. But at present, when some organizations in the public sector are working on this scheme, the pressure isn't great on your part, but how can you provide more financial help? It's good to provide assistance, but you also need to consider whether the threshold is too high. This is what you need to take into account. Thank you, Chairman. There are a couple of carer-centric centers. They have obtained support from the private sector. The administration is more than willing to provide support. We will also monitor the threshold. We've already gone through the 2 items on the agenda. Agenda item number 3, AOB, any other business. I'd like to say something. The subcommittee set up under the House Committee needs to finish the work within 12 months. We also need to submit a report. So in this connection, Undersecretary, as I mentioned just now, I hope you will summarize the work we've done in the past 12 months. It's high time we consolidated the carer-centric policies in order to submit the report. So let's see if we can get this done before the next meeting. I'll need to discuss with the Secretariat and the administration the date of the next meeting, which will be scheduled in April. It will be the last meeting. Let's see if we can complete the report. You've done a lot on carer-centric policies, but then you have not compiled the report. The information may seem piecemeal. So we'd like to have a report so that we can submit it to the Council as well as the public. Ms. Connie Lam. Thank you, Chairman. I'd like to respond. In the report, I suggest that it detail the suggestions of members. I'd like to endorse the work of different sectors. There are different events held, such as there are cheer-up days and fun days for carers. And it's important to have a database. Can you let us know whether you will work on it? Do you have a timeline? Let's first put what we have done in the report. Ms. Lillian Kwok, please be succinct. I'd like to have 3 papers, one on training courses. That is the training courses for care team members. Next, you mentioned the report, which is also what I mentioned just now, and the effectiveness of the 19 district elderly community centers. Well, I mean the 19 PRCs. I'd like to have the paper before the next meeting. Under Secretary, I'll discuss with the Secretariat in a moment. If there is no AOB, meeting adjourned. I thank the administration for joining us today. Thank you. Meeting adjourned.